Good afternoon, everyone. Thank you so much for joining us today. I'm Io Sanderson Wilson. I'm the founder and CEO of Empower the Village. I want to thank you all for making time for this very important workshop today. For those who don't know, Empower the Village is a data-driven 501c3 nonprofit organization that's focused on restoring prosperity, peace, and power to the Black and historically marginalized communities. Today, we're partnering with Ardelyx, who is the sponsor for our Wellness Wednesdays, on this very important virtual workshop, because what we're here to talk about today impacts the communities we serve. We always do our work in the strategic partnerships model, and today you'll see how these strategic partnerships are helping us to achieve our goals. We're here to inform you today about the impact of kidney disease and the importance of affordable access to the most innovative treatments that are out there to make sure that everyone has access to the care that they need. Unfortunately, Black people and people of color in the United States are disproportionately impacted by kidney disease. And today you're going to hear from two really knowledgeable panelists from Ardelyx. First, we'll have our Dr. Alan Ryan, the Senior Director of Patient Advocacy at Ardelyx, and they are also the creators of Exposa, an innovative phosphorus-lowering treatment to help treat kidney disease. Next, you will hear from Dr. Laura Williams, who is the Chief Medical Officer at Ardelyx. Before I turn it over to Alan, I just wanted to make sure that you know that we will cover many of the things that are probably on your mind. First, we'll be talking about what exactly kidney disease is, what are the early warning signs and symptoms, how is it diagnosed and treated, and learn ways to improve the outcome for kidney disease, including what the innovations are in the space, in order to ensure that we can reduce the risk of death and advanced disease. So there's a lot we're going to cover today, but what's important for you to know is how to take care of yourselves and how to advocate to ensure that you have access to the most innovative treatments there are. And with that, I'll turn it over to Dr. Alan Ryan.
Hello, this is Alan Ryan. I am glad to be part of this great webinar. And I'm a pharmacist by training, actually a proud graduate of Howard University. And kidney disease is something that is close to me in the sense that I lived with my grandmother in high school and drove her back and forth for kidney dialysis treatments because she was a diabetic. She had high blood pressure. And then she also, unfortunately, had kidney disease, which is the shutting down of your kidneys from functioning. And so then you have to essentially have an external machine to process your bodily fluids in a way that allows you to get the impurities out, and that allows you to continue to live, quite frankly. So kidney disease is a very serious matter. There are 500,000 people in the United States who are kidney disease patients who also have to be on dialysis. Up almost 20% of those patients annually die. So it's a very serious matter to be a kidney disease patient who is taking dialysis. And of those 500,000 patients that are on dialysis, 35% of them are African American or Black patients. And as you know, we make up 13% of the population, but yet we make up 35% of the patients on kidney dialysis. So this is a very serious matter for our community. And in talking to kidney patients, which is something I get to do regularly, they routinely will share how difficult and how challenging it is to manage their health. I actually asked one patient how difficult it is to manage their health on a scale of 1 to 10, and they said it's a 15. So this is a very serious matter that we should be trying to help patients who are afflicted with this to make things as good for them as it possibly can be. And so towards that end, patients who are trying to manage this serious disease and their doctors really need to be allowed to make the best decisions to manage their own treatment. And as we all know, there are lots of factors that go into whether or not a doctor and a patient are allowed to make the best decisions for their treatments. And some of those things include some of the laws and reimbursement regulations that impact patient choice and physician choice on what patients patients are allowed to get. And so I will just say in a general sense, it's important that all patients speak up if they're not getting what they need. And it's most particularly important that kidney patients who are, again, a very vulnerable population, speak up to make sure their needs are met. And with that, I will be happy to hand it over to Dr. Laura Williams, who's going to give a more in-depth conversation to us about kidney disease. But my hope is that we will all speak up to champion patients. To you, Dr. Laura.
Thanks, Alan. It's a pleasure to be with you guys today. I am Laura Williams. I'm the Chief Medical Officer at Ardelyx, and I'm an internist by training with subspecialty training in infectious diseases. But I've been working in the pharma and biotech space for the last nearly 30 years, working to develop drugs that address unmet need. And one of the needs that we're going to talk about today, obviously, is for patients who are on maintenance dialysis because they have end-stage kidney disease. But before we get there, I want to just pick up a little bit on what Alan was saying as it relates to some of the social determinants of health. Particularly, we will focus today on policy because policy is one of those things that can become a determinant of health outcomes. In addition to where you live, your education, where you work, all of those things play a role, I think, in terms of health outcomes. But policy is a very important one. And so toward the end of the conversation, I'm hopefully we'll get you to the crux of the issue, which is a policy issue that I think we can all sort of weigh in on, hopefully, to make a difference for these patients. But before I do that, just to give you a little bit of background, Alan started the conversation as it relates to chronic kidney disease. 37 million people in the US actually are impacted by chronic kidney disease. And what's striking is that 90%, so 9 of 10 patients actually don't know they have it. So when we talk about signs and symptoms, it's one of those diseases that really is kind of silent as it relates to signs and symptoms. You don't necessarily know that you have it. And so it is important to make sure during your, sort of checkups that you actually, implore your healthcare provider to talk to you about your kidney function. And there are simple tests that they can do to let you know exactly where you stand. But when we talk about chronic kidney disease and we talk about the etiology, the cause of it, the number one cause is diabetes. Number two is hypertension. There are other causes of chronic kidney disease, like there's genetic causes. There's a form of chronic kidney disease that's associated with being out in the extreme heat for extended periods of time. So you talk about construction workers, laborers, those patients can get, repetitive bouts of dehydration that eventually impact the kidneys and lead to chronic kidney disease. Now, all of the patients, obviously, who get chronic kidney disease don't progress to end-stage kidney failure, but a good number of them do. And Alan talked a little bit about that. I think the best way to prevent end-stage kidney disease is obviously the preventive measures early on. So if you have diabetes, if you have hypertension, treating those underlying diseases are really the key. And there are, fortunately, a number of drugs available now that can delay the progression of disease so that hopefully you don't get to that situation where the kidneys have failed. But let's say you do. As we know, a lot of patients do. As Alan noted, about 550,000 patients are impacted this way, and have end-stage kidney disease. And really the only treatment for those patients is what we call renal replacement therapy. And that comes in two forms. One is dialysis, and the other one is a renal transplant or a kidney transplant, right? And so 2/3 of our patients who have kidney failure end up on maintenance dialysis, while another third actually are able to get a transplant. I think some of the numbers that, again, Alan talked about is just the disproportionate impact that it has on different populations. For example, when you look at Blacks, there's a 4-time higher rate of kidney failure versus whites. And in terms of transplants, even though Blacks are disproportionately impacted, they're less likely to get transplanted by about 2 times, right, versus white patients. So again, social determinants of health are there. I think one of the things that we wanted to really touch on today, though, is like one of the complications or some of the complications that patients, once their kidneys fail, have, and there are a number of them. There's a slide that I'd like to share with you that just sort of touches on some of the complications that we see in patients with dialysis, with kidney failure. And this first slide is depicted here. So all of these things, these big names, secondary hyperparathyroidism, elevated calcium or hypercalcemia, anemia, all of these things are things that dialysis patients actually have issues with, or complications, if you will, of the fact that their kidneys have failed. But what I want to point out from this slide is that among all of these things, it's elevated phosphorus that carries the highest risk of mortality. And that's that, sort of light orange bar on the left side. And so there are a number of complications that patients have once they're on dialysis. But one of the ones that has or carries the greatest risk of mortality is elevated phosphorus. And that's why this topic today is really, really important. If you look at the next slide, it basically shows you that with every increase of a milligram per deciliter in phosphorus levels, you increase the risk of death. And so this is a big problem, hyperphosphatemia. And now we can take the slide down and let's just talk about this issue a little bit more in detail. One of the things that when we look at, sort of the payment system for patients who are on dialysis, CMS, the Centers for Medicare and Medicaid Services, back in 2011, well, first of all, in 1972, decided that they were going to pay for all of the, cost related to dialysis patients, right? The dialysis service itself, all of the medications, all of those things. That was in 1972. In 2011, they made a change to the system to go from a fee for service sort of payment system to what we call a fixed bundle system. And so that fixed payment system, what we call the bundle, is there, and it is basically a bundle payment for everything that happens for that patient when he or she sits in the dialysis chair. So it pays for the dialysis session, it pays for any medication that the patient has to have during dialysis, pays for the staff who are taking care of the patient, and it pays for any blood work. And as you can imagine, as time has progressed, the number of drugs that patients have to take, during a dialysis session could easily increase. But if you're on a fixed payment system and you don't increase the budget in that system, then you essentially run out of money. And at the end of the day, you're not able to often, be awarded sort of the new innovative therapies. And so one of the things that CMS is now proposing is putting these drugs that we use to treat patients with the elevated phosphorus, we call them phosphate lowering therapies. Historically, there was one class of drug called phosphate binders. And just like the name implies, you take them with food, they bind the phosphorus that is in your gut in the food, and that phosphorus goes out in the stool, because once the kidneys fail, you can't get rid of the excess phosphorus. So the only way you can do it really is either, is really through medications. The other class of therapy, the newer one, the one that we just innovated on, is a phosphate blocker, or a phosphate absorption inhibitor. So instead of binding phosphorus, it blocks its absorption. And some of the differentiated uh, things about the latter one, the more innovative one, is that it's a smaller number of pills. It's 2 small pills total per day, as opposed to the phosphate binders, which are typically 3 large pills with every meal. And so we thought that we've been working on this for a long time, thought it was a very innovative way to actually, lessen the burden on dialysis patients. But at the end of the day, CMS has now said we want to put all of these drugs, binders and blockers, all of these phosphate lowering therapies into the bundle. And we think that's a problem. We think that's a problem because when we look at examples where they have done this before for other drugs, it has caused a huge problem for patients. What are those problems? It has limited the access to the newer drugs so that dialysis organizations are using a protocol that says it's a one size fits all. So it takes away that shared decision making that the physician should have with his or her patient. It also limits the access to the innovative drugs. And what we now know from a new study that was just published last week is that those changes are actually detrimental in terms of outcomes to our patients. And again, when you look at the disproportionate number of Blacks who are affected with kidney failure versus non-Blacks, that is particularly problematic. And so Congress has acted 3 times in the past to say these phosphate lowering therapies should not be put into the bundle. The problem, though, is that the last legislation that Congress passed to keep these drugs out of the bundle, that legislation will expire on December 31st this year. So starting January 1st, 2025, if Congress does not act again, those drugs will actually go into the bundle. These phosphate lowering therapies to manage a condition that has a high mortality and a high morbidity, those will go into the bundle. Patients' access to the more innovative therapies, as well as the other therapies, will now be shunted, right? It'll be distorted. And that shared decision making that, physicians generally have in terms of trying to manage phosphate levels goes away. That is a problem, particularly for patients of color, but for all patients. And so we don't want that to happen. And as a result of that, there has been bipartisan, bicameral support of a new legislation called the Kidney Patient Act. And it was passed both, there's a bill that was put out both from the House of Representatives, it's HR 5074, and from the Senate, which is S4510. And so there's a bill called the Kidney Patient Act that seeks to, again, delay putting these drugs into the bundle. And we think that's the right thing to do. And you can help with this as well by contacting your congressional, support groups to make sure that you voice your opinion to say these drugs shouldn't be put in the bundle. We think it hurts patients, it limits their access, and potentially leads to poor outcomes. And so with that, I'm going to stop and turn it back over to Io. And I think we have a Q&A session coming up as well.
Great. Thank you so much, Dr. Williams. So as I started saying at the very beginning, Empower the Village is about empowering our community, and we empower you with information. And so this session was about educating you to be sure that you understand what kidney disease is and what can happen if you progress to kidney disease, but also give you the tools and resources so that you can make your voice heard. It is critically important that our community that's overrepresented in kidney disease and kidney failure have access to the best-in-class treatments, and that policies do not block us from that access. So at this time, I want to make sure that we answer all of your questions, and then later you'll have an opportunity to click a button. It's very simple, to make sure that your congresspeople, your senators hear your voice. And you can sign a petition to make sure that the Kidney Patient Act moves forward and that your rights to innovative treatments is protected. So I'm going to check right now with our webinar hosts to see if we have any questions. All you have to do is put your question in the Q&A. So you click on the Q&A button to submit your questions, and we will be sure to have Dr. Williams or Dr. Ryan address your question. Okay, so we have a first question. What are the consequences, and I know we touched on this a little bit, but maybe give more of an example. What are the consequences of putting these drugs in the bundle? Why is this policy so important? And I know Dr. Williams and Dr. Ryan, in our initial conversations preparing for this, there was conversation around the fact that dialysis patients cannot take this particular drug during their dialysis treatment, and how separating it makes it more complex for them to get what they need. But I want to let you speak to that.
Yeah, I think that's a very important point that is worth making. And I will also show an example of other drugs that have been put into the bundle, and why that has been problematic for patients. But to speak to your point, first of all, we have said that these phosphate lowering therapies are, they basically either bind with food or they block the absorption of phosphorus after you've eaten. And so the main requirement is that you have to take these drugs with food or in association with your meal, and you can't eat during dialysis. And so these drugs actually can't be administered at a dialysis facility while you are receiving dialysis. So they're not part of a renal dialysis service, and for that reason alone, should not be included in that bundle payment system. They shouldn't be included as drugs that are absolutely necessary to be given during dialysis, because in fact you cannot give them during dialysis. But a bigger piece, there is another slide that I will walk you through. This is a study that was done that actually just got published last week, and so this is a nice diagram. It's from a nice database that's been around for a long time, the Dialysis Outcomes and Practice Patterns Study, or DOP study. And this particular study looked at a number of patients, 713 patients that were enrolled in dialysis centers across the country. And what this study looked at is what was the impact of putting a drug that is used to treat one of those complications that dialysis patients get. It's called edacalcetide. You don't have to remember the name, but it's in a class of drugs called calcimimetics. So this study looked at what was the impact of putting this drug into the bundle system. And so what they did is, whenever they're deciding to put a drug in the bundle system now, what they have is what we call a transitional drug adoption period, or TDAPA. Basically, it's a period of time where before the drug goes into the bundle, they sort of try to figure out the utilization of that drug so they can then determine how much of an increase they're going to add to that bundle payment. And so that is TDAPA. And so this study looked at, okay, what happened with the utilization of this drug before and after it was put into the bundle. And in the caption in the middle of this slide, you can see that the use of this particular drug went down 58% after it went into the bundle. Okay, so one of the things that CMS always says is that when we put these drugs into the bundle, that's going to increase access and utilization. But in fact, that is not the case. Nearly 60% decrease in utilization of this drug once it went into the bundle. And now, if we were to look at utilization today, it's actually less than 1%, even though patients need this. A lot of patients who are on maintenance dialysis need this drug. I won't just stop there though, because the bigger piece, if you shift to the right of this graph, at the end of the day, what are the outcomes as a result of that? Well, when you look at the measure that this drug controls, which is PTH, you don't need to worry about the fancy long name, but it's a hormone. And basically, when you use this drug, it decreases that hormone, and it increases, it helps the patient, right? So once this drug was stopped, you can see 6 months after that decrease in the utilization of this drug, those PTH levels went up. That's bad. And that represented a 15% increase in levels once the drug was stopped. And that was in all patients. But if you look among Black patients, it was even worse, with a 23% increase in those levels. And so that is problematic, because people have tied increased levels of this hormone to increased mortality. So let's just break that down. You put these drugs into the bundle, you get decreased utilization, and you get poorer outcomes. That's the bottom line. There is a less innovative version of that drug that they switch patients to, and even when they switch those patients to that less innovative drug, they still saw these bad outcomes. And so that's the whole point. We want innovative drugs that actually make a difference in terms of the outcomes that we see with our patients. And so this is CMS's best example of what they say works well. Well, this doesn't work well for patients. Poor outcomes, less access, and the shared decision making has gone away. We don't want this to happen to our phosphate lowering therapies.
Thank you so much for that. We have many more questions, a couple more. We'll see how many we can get through in the chat. So the first thing was, it seems like a no-brainer, right? Based on what you described, the information that's provided, we're trying to save lives and make sure people get the best-in-class treatment. So why is the government making this change when they have evidence that when they bundle things together, quality of care goes down and outcomes are worse? So why are they doing this?
Yeah, I think that's a good question. And I think it really is an unintended consequence of just a process-oriented, antiquated payment system, right? I mean, when they originally started this in 2011, it was really based on a different class of drugs that were used to treat anemia. And it made sense at that time because there was a lot of data to say that we were overusing that drug. But the data itself was enough to sort of decrease that utilization. You didn't necessarily need a system that forced decreased utilization. Now, with all of these other drugs, it's not based on data. And so I think it's just part of a process that was, designed in 2011 to decrease utilization and decrease cost. I'm all for making sure that we are efficient in our cost, sort of projections, but I'm more, interested in making sure that patients are treated in the best way possible so that there are quality-based outcomes. There should be metrics involved that say that what we are doing is actually helping patients and not hurting them. And so this one is a no-brainer, and we've got bipartisan support. We've got support across, pretty much every advocacy group you can think of. And so and as I said, Congress has acted 3 times in the past to say this is not the right thing to do. And the hope is that Congress will act again to make sure that we protect our patients.
Thank you. As you know, Congress doesn't act unless the people act, right? So we need the people to get their Congress people to do the right thing once again. So we do have another question, and it is, let's see, is there a particular blood test that needs to be requested to check for kidney disease, or is it part of a typical physical?
Yeah, there are a couple of tests. One is a simple urine test, where basically They collect the urine and they're looking to see if there's protein in your urine. And the reason for that is that when the kidneys start to fail, or the function starts to get worse, you leak protein in the urine. So that's a signal. But there's also a blood test that measures kidney function, and it's called creatinine, and they use that value to figure out what your overall kidney function rate is. It's a simple test, and if you don't remember the names, all you have to say is, I want to make sure that you check my kidney function. And it's part of a routine, chemistry panel that they can test along with a simple urine sample.
Great, thank you. So as we heard earlier, a third of these patients that are going to be in need of the most innovative treatments and the phosphorus lowering medications are African American patients. And in addition to that, there are Latinx and other people of color who are impacted by diabetes and hypertension. And yet the signs and symptoms of kidney disease are not necessarily observable without these tests. So we're encouraging everyone to make sure that they get checked. The next question is whether or not, and I think this question is probably for you, Dr. Ryan, it is about what steps Ardelyx is taken in consideration of those patients. What is it that you are doing to ensure that that patient community is being cared for?
So first, I have to say one of the things I'm really proud about what this company has done is in clinical trials, it's very common for clinical trials, candidly, to not include us or not include us at a rate that we're in the population. We make up 13% of the population, so we should be 13% of a clinical trial. Or we may make up 20% of a particular disease, and then somehow the clinical trial will be done, and only 5% of the clinical trial participants will be Black. But in this instance, for our product, over 40% of the patients that were part of the clinical trial that proved that the drug works were in the clinical trial, right? So this demonstrates a high degree of intentionality, forethought, frankly, of making sure that the company is being patient-centric and making sure that the product, in fact, does work on the patients that the drug is going to be used on. So that's one base element that was done before we even got to an approval of XPHOZAH. Now, on the other end now, where we're actually at a place where we're trying to preserve access to medicines for patients, one of the things we're doing is we're partnering very widely within our community to make sure that the word gets out. First of all, we're doing a lot of education, like working with your organization, IO, with Empower the Village, to do webinars just like this to get the word out. We've also worked closely with the National Minority Equality Forum. And also, just so everyone knows, the National Medical Association has said that this is a policy that they are supportive of. They are supportive of the Kidney Patient Act. And the National Medical Association is essentially the Black doctors organization. And so we've worked with them as well as the HEAL Collaborative, which is another organization. So essentially, we have been working with a number of organizations that reach the Black community to try to raise awareness and education about kidney health as well as this important issue.
And if I can just add to Alan's point, which I completely support, just to be even more specific, in our clinical trials for XPHOZAH for patients who are maintenance dialysis, 45% of patients were Black.
Wow.
And 28% were Hispanic. So we were very intentional in trying to make sure that our clinical trials were representative of the patients who had the disease. And the second point I want to make is that we also at Ardelyx have, I think, an excellent patient assistance program where it actually supports patients who are underinsured or uninsured and who are prescribed our drug. We do everything we can in that system to make sure that patients have access to our drug. Just wanted to add those 2 points.
Excellence. Yes, affordability is key to access and policy is the other key, right?
Right.
So I want to definitely thank you both for sharing all of this information. I think now it's time for the audience. I think people are asking, what can we do? So what you can do is actually coming right up. It's important for us to know, but it's also important for us to act. And so with the Kidney Patient Act, that is our opportunity. There's a QR code on your screen. If you scan that QR code, we will be letting know, you will be letting your voice be heard and letting our policymakers know that you are supportive of the Kidney Patient Act to ensure that those innovative treatments that we're talking about that are going to save lives, particularly in our community, but in all communities, we get access to them, and we get access to them in ways that will ensure that we're getting best in class treatment. So please take a moment to scan the QR code. We also have additional information available for you to learn more about the Kidney Patient Act and the implications of the bundle that we've been talking about. So if you go to Kidney Care Equity, that's kidneycareequity.org, there's even more information on this very important topic. So we're hoping that you'll take a moment. I think either in the chat or in the Q&A, there'll be a link that you can click on. And there's a pre-populated survey or petition that you can send to your congressperson, but please take advantage of that. This is a recorded webinar, so you can definitely share the link with friends and family when it's over. And we'll, of course, make sure you receive it in the newsletter again. But I want to take a moment to thank Ardelyx for sponsoring our Wellness Wednesdays, sponsoring this very important workshop. Thank you to Dr. Ryan. Thank you to Dr. Williams. I'm incredibly impressed because given my background in pharma, knowing that your clinical trial has made strides in ensuring that the people who are affected by the disease are part of the trial and make sure that the medications and treatment are meant for and working for those populations is a big deal. Doesn't happen often. So we appreciate you as our strategic partner and our sponsor. And with that, if you all have any final comments, feel free to make them. Okay, I think we're good. We've answered most of the questions. Thank you all for joining us. Empower the Village is here to empower you, and making sure that your health and wellness is in order is a big piece of what we're here to do. Thank you for listening. Have a great day. If you have questions for us, you can always email us at admin, ADMIN, at empowerthevillage.org, admin@empowerthevillage.org. So please enjoy the rest of your day. Thank you for taking the time.